Hello and welcome to Anderson Community Television. I'm Carol Donahue, your host today of a special edition of Meet the Doctor. Our guest today has been successfully striving for excellence in orthopedic surgery since 1995. His practice involves sports medicine, knee, hip, joint replacement, as well as foot, ankle, elbow. Missing anything? No? He earned a fellowship at the prestigious Cleveland Clinic. He attended the University of Cincinnati Medical School. I'm pleased to welcome Dr. Suresh Nayak, orthopedic surgeon with Wellington Orthopedic and Sports Medicine. Welcome, Dr. Nayak.
Thank you, Carol.
So how's it going?
Pretty good, thank you.
Good, good. I'm telling you, I take classes at the HealthPlex. I think you are the star. Your name comes up continually. I'll see a little scar in a knee, and somebody will tell me, "Oh, it was so much easier than I thought it would be, and I was so pleased." And I'll say, "Who was your doctor?" "Dr. Nayak. Do you know him?" And I said, "Well, I'd like to know him if I should, need some health problems, or some knee problems." So you are the star there.
Now you know why I don't work out at the HealthPlex.
That's right. Oh,
I could never get my workout done.
That's right. That's right. Now, recently, there was an alliance between Wellington and the hospital. Is that true?
Yeah. Wellington, I back it up a little bit to what's happening in healthcare today. There's a lot of uncertainty with the Affordable Health Care Act. Imagine trying to run a business where you don't know where your revenue is coming from, whether it'll be going to be dropping 30% next month, how your payments are going to be. It's very difficult to kind of project out 2-3 years from now where things are going to go. It seems like, and again, I can't predict the future, but it seems like payments are going to be distributed through hospital systems now. And in Cincinnati, we have at least four very fine hospital systems, Mercy Health being the one that we've chosen to align ourselves with. And so the partners basically sat down and looking at the landscape. Obviously, nothing's really the same as it was 20 years ago, 30 years ago, in whatever we do. I mean, we didn't have the internet when we first started all this. And thank you to Al Gore for developing that for us. But trying to run a business and try to take care of people, it's very difficult in this environment. And so my practice and a lot of our other partners' practices was at Mercy Health, and they're very nicely distributed throughout the city as far as locations and ease of access. Their administration is very easy to work with, and we formed a partnership years ago, and then we formalized that partnership recently. Across the city, though, I think more and more of the physicians are aligning themselves up with one of the hospital systems. So that doesn't preclude us from working at other hospital systems, but we've aligned ourselves with the Mercy system currently.
So is that changing how you're seeing your patients now?
Nothing's really changing except the bill that you get is not from Wellington, it's from Wellington/Mercy. It should be seamless. Actually, it's allowed us to not really focus on, the intricacies of running a business, but we just see patients now.
Which you really were trained to do.
This is what we do. Yeah.
Now, I know I've seen so many articles in the paper where you're speaking either at the hospital or at the HealthPlex, something to do with knees or hips. Are you starting to get a little bit more into education?
We've always been involved in education. I've been in practice now for 17 years, and I'm an associate clinical volunteer professor of orthopedic surgery at University of Cincinnati. I've been involved in the residency training program now for 17 years. I teach down at the VA hospital, the residents down there, and give back to our vets who have, given their lives for us, and doing my small part there. So we've always been involved with education. I teach at the university, give lectures down there, as well as train the residents. We have every 4-month block, I have a chief resident, so a 5th-year resident. So after 12 years of high school, after 4 years of college, after 4 years of medical school, 5 years of residency, I get them at the end of that I think it's grade 24 that I get them at.
The 24th grade.
The 24th grade. And then it's basically spit shining and polishing, you know, making sure that they know the latest techniques. And it's been wonderful. You know, there's a lot of camaraderie. They keep us on current, and it's another way to give back to the community because, you know, we all didn't come to this world knowing everything like you did. Somebody had to train us.
Thank you for recognizing that.
Your husband told me to tell you that.
Oh, thank you. Now, also, talking about giving back to the community, you're involved with Forest Hills, too, correct?
Yeah, one of, we started this a while back with Wellington and our outreach program, taking care of the different high schools, Turpin, Anderson, the middle schools, and all the elementary schools. There's been affiliations with Wellington and a lot of these schools. We actually do about 15 or 16 different schools around. And then with Mercy coming in and really bolstering this, not only with funding, but also with programming, with educational offerings, putting trainers at each one of the schools. You know, they've come in and really blown this thing up, and to the benefit of our community. So as a part of that whole framework, I'm involved with, I volunteer as a team doctor for Turpin. I've been doing that for a few years now. Dr. Favorito, one of my partners, does the same at Anderson. We have many of our doctors who practice sports medicine, you know, dedicate their part of their time to taking care of the athletes, student athletes, staff, coaching staff, that kind of thing. And it turns out to be the extended family as well.
What percentage would you say of your practice is sports medicine, and what part would be average wear and tear or aging?
You know, it's hard to say. You know, I had a 70-year-old come into the office playing racquetball and tore their meniscus. Now, are you going to categorize that as a sports medicine injury?
That's true.
And I would say absolutely, right? Versus
right.
somebody that's wear and tear. So the definitions are a little bit, you know, we take care of people that have injuries, musculoskeletal injuries. So I primarily do hip, knee, shoulder, but we do a lot of ankle work as well. We have subspecialists that if it gets complicated, we can refer to. We have the opportunity to work with 35 different doctors. Each one of them has a general knowledge and then a subspecialty area of expertise that they will you know, specialize in. And we are able to tap into all of that. So if it's something that I do and I do well, and this is really what the rest of our practice does as well. If we do it well, we'll take you through that process of healing. And if there's somebody in our practice that does it better, we have the ability to refer on.
Well, that's wonderful. I think we have some visuals here for knees.
Yeah, this is, you know, this is just a visual as far as what we were talking a little bit earlier about what arthritis is, et cetera. Arthritis is a condition of the cartilage, which is the bearing surface on the edge of our bones, and two bones come together in a joint. This is particularly the knee joint. I don't know if you can see this picture, but this is the femur and this is the tibia right here. The joint space is that's what's in between there, and that's not filled with air, that's filled with cartilage, which is a very thin layer of specialized tissue that lets the two surfaces glide past each other. And what happens in arthritis is we lose that cartilage space and the bones touch. It can happen in the inner aspect of the knee, the outer aspect of the knee, or it can happen between the kneecap and the thigh bone. So, and when that happens, obviously that's a very painful thing to have happen. It affects your activities of daily living. You can't walk, the knee swells up, it gives out, and it's very debilitating. So what part of our, you know, this is the last stage. We do everything before surgery for these people, including activity modifications, weight loss. You know, at our health plexes, we have the warm water aquatic therapy, the Arthritis Foundation programs to help people lose weight without banging on their knees. We have medications that we can coordinate with your family doctors. We can inject knees with different types of compounds to try to reduce pain. And then there's surgical intervention. If you have a normal looking knee and perhaps you've torn your meniscus, that's what we do arthroscopically to try to trim out meniscus tears, clean out your knee. If it's like this, though, a lot of times, and you've failed every other conservative management, and a knee replacement is an option, either partial or total knee replacement.
I see. So I was happy to hear that you try so many things before you go ahead surgically.
Yeah, average time, when I see a patient, it may be years before we all collectively decide on a knee replacement. This is not unlike my house, this is not a dictatorship. This is a decision by committee. So, and the patient or the customer that comes in is the one that decides. And we try the least invasive to most invasive type of treatment, and then the patients are involved in their decision making at every turn. And the advantage of having one foot in sports medicine and one foot in we call this reconstructive surgery or arthroplasty, is that we can try to tailor make the treatment for the patient. In other words, if you go to see a doctor or an orthopedic surgeon that just does arthroscopic surgery, you may be going into a knee arthroscopy with this type of knee where there's nothing left, because when you're a hammer, everything's a nail. That's all I've got to offer you. Versus if you go to an arthroplasty surgeon that just does total knees and total hips, then they may operate on you prematurely where you may want to try different things first. Arthroscopically, or osteotomies, where we cut the bone and realign the bone so that we can offload the part that's worn out and let the other part wear out a little bit. So there's all kinds of different options that you should try before surgery.
If someone opts for a total knee replacement, I know a lot depends on their physical condition, their age. What is the recuperative time for that?
Everybody's
generally
different, and it really depends on what you mean by recoup time. And that's where really patient expectations really matter. So there's a long discussion before surgery, and I hesitate to operate on somebody that I've just met for the first time. It's kind of like dating. You want to make sure it's a relationship that we're forming, and you want to make sure it's trust. It's making sure that I know what you want and you know what I have to offer. So if you're expecting a pain-free knee at 3 weeks, you're going to be disappointed with me, because it's not going to happen. Nobody in this world can do that for you. But if you have realistic expectations, you may not like it, but at least you know what you're getting yourself into.
And isn't physical therapy sort of the key to bringing that all around?
Yeah, what happens when you have an arthritic knee is really a gradual deterioration of function. You can't be active. Your muscles atrophy. Your knee gets stiffer. Your cardiovascular system, you're not able to do as much. So you're sitting around more.
Are you not looking at me personally?
No.
No. Okay.
I'm looking at the camera.
Good. Okay, you're all right.
But this is what happens to people, and you've had back surgery. I've had back surgery. It happens to us. After my back surgery, I don't know how it was for you, but it took a good couple of years before I was able to do everything that I wanted to do, and I was pain-free. And it wasn't bad, but it wasn't normal. And physical therapy was the key in that. Actually, we're now trying to get our patients in physical therapy, aquatic therapy, before surgery, so that you can increase your function, muscle strength, range of motion before you even get to surgery. And then those people have been shown to, in various studies at big centers, to do better than the patients that go into it blind. Because really you're recovering not only from surgery, but from the process of getting arthritis, which has robbed you of range of motion, strength, endurance, cardiovascular, fortitude, for lack of a better word, for the last several years. So if you get a flu for 3 days or 4 days or a week, it takes you a good month to bounce back from that.
Oh, yeah.
Imagine just sitting on the couch watching Oprah for, a year or two, not being able to do the things that you normally want to do. And that's really where you should focus. How long does it take me to bounce back from surgery? Well, how long did it take you to develop
to this point?
Exactly.
Yeah.
So if it took you 2 years to get to this point, it's unrealistic to say I'm going to be normal at 6 weeks or 8 weeks. But most of the people by 3 months, 6 months, a year achieve what we would consider to be a plateau state, meaning that you've got great range of motion, you've got reasonably good strength, endurance, and you can do most things that you want to do.
Now, do you do this type of robotic surgery as far as the knees are concerned?
So the robotic surgery has been FDA approved for a small percentage of people with partial knee replacements right now.
Okay.
And we're involved with one of the big manufacturers that is trying to widen that platform to include the total knee replacement.
I see.
And you know, is it technology over reason? We're not sure yet, but you know, I'm involved in that research right now to see if right now we're doing computer navigation, where with a computer we're able to input all the data anatomically about what the knee looks like. I'll show you a model here. This is basically what a knee replacement looks like, and it's basically a resurfacing operation of the various different parts of your joint. So this is the femur, this is the tibia, so the thigh bone and the shin bone. And when they come together, before on the other model we explained that the cartilage was the bearing surface between the two. Now in the knee replacement, what we're doing is resurfacing the edges of your bone simply by removing about 10 millimeters of bone off your thigh bone, replacing that with a metal cap. And then on the shin bone side, the tibia side, taking about 10 millimeters of bone off of the shin bone and putting a metal and plastic composite in there and realigning you so it's not bow-legged or knock-kneed, but it's basically straight. And that's your new bearing surface. That's simply what a knee replacement is. And so the various different, so the computer helps us in deciding what the size is from the front to back to side, to how much bone to take from each surface.
Exactly.
And then when we cut the bone, the computer tells us how we've done to make sure that every cut is perfect. And so that when we put all of this together, the knee works perfectly in space, the sizing is correct, the kinematics, how the knee works during the entire range of motion is perfect. And also the range of motion. We can tell if we're lacking a little bit of range of motion, we can actually make adjustments in surgery so that we get it perfect before we leave the operating room. We liken this to buying a new set of tires, and the guy that's putting on the tires, whether it be Michelin or Pirelli or whoever the big name is, but if the guy doesn't align them perfectly and front end balance them perfectly, will the tire last as long as it's going to be?
I see. I see.
And so the computer navigation and all the studies that have been out basically make the surgery, make the outlier so it's done reproducibly every single time. So the next advance after computer navigation is letting a robotic arm come in instead of my arm doing the cutting. So that's the next advance.
I see.
So it's a stepwise fashion.
I see. So how long has this procedure been in force? How long have you been doing it
So
this way?
knee replacements in general have been in for probably in various different forms for about 40 to 50 years, probably more common in the last 20 to 30 years. And then we have something called the FDA that we have to get these things approved through. So that adds probably a good 5 to 10 years to any new idea that I have that I want to bring to market. There's a validation process that has to happen. And that's why we can't just say I'm going to my robot from Toyota to come in and do this work. We have to have checks and balances. So the computer navigation we've been doing successfully for probably the last 8 to 9 years. So we've probably done several thousand that way.
Does that shorten the length of the surgical time?
When we first started to do it, it lengthened it by a little bit because we had a couple more steps. Now we've got it down to about 35, 40 minutes.
Really?
Yeah.
So a person having this procedure done, they can expect a tad of discomfort, but you try with medication to keep them.
Yeah, one of the other, big advances I think in doing surgery of any sort has been anesthesia. How to help people through the painful process of having your leg cutting in half and beating it with a hammer 100 times. And you do give me permission to do that if your pain is bad enough.
Help me.
In the Civil War days, when they were performing surgery, it was very quick because we didn't have very good anesthesia. Then ether was discovered, and then we could, do a little bit more, but still the length of surgery was limited. Now, with general anesthesia, with regional anesthesia, spinal anesthetics, epidural anesthetics, nerve blocks that will give us extended pain relief for 2 or 3 days after surgery, boy, we can really, be effective in controlling pain and enhancing recovery. Our hip replacement patients on a routine don't stay in the hospital more than 24 to 36 hours. When I first started practice, we had them in hospital for 3 weeks.
So what's the stay for the knee replacement?
I mean, some people are doing an outpatient. Most people stay a day or two. Some people stay 3 days if they don't have family members that can help take care of them. They have to go to a rehab center. But really, it's when I see patients in the hospital now that I've done surgery on, first and second day after surgery, it's more social rounds, meaning everybody's really comfortable. Nobody's on morphine, pain pumps, and kind of talking out of their heads and writhing in pain. They're very comfortable participating in their rehabilitation. We try to get you up out of bed that day.
How about bending the knee?
That starts in the recovery room with either CPM machines, or now we've gone to a drop and dangle protocol where you're sitting in a rocking chair and just bending your knee back and forth the day of surgery.
Really?
Absolutely.
I'm impressed. Well, there was a lady in my HealthPlex class. She was gone for maybe 3.5 weeks, and I said, "Where have you been?" She said, "I had hip replacement surgery," and she was back in the water, the warm water, in 3.5 weeks.
Yeah.
And the incision was in the front.
Yes, that's something, again, probably the last 4 or 5 years we've been doing. Hip replacements have been around for 20, 30 years, maybe a little bit longer, but done in a routine fashion for that long. And traditionally we've been doing it from the posterior approach, or from the back, where you have to cut some of the muscles that, and the capsule, the ligaments that keep the hip from popping out. It's a very good procedure. It takes care of pain. The technology on doing hip replacements has advanced. The hips that were lasting 10 years are now lasting 20 years, 30 years, depending on how you use them. But the technique on putting hips in has evolved. Now, we used to go for a lateral approach where we had to cut some muscles as well. Now we're going from the front with some of the new technologies and new approaches that we have. We're able to do the surgery in the same amount of time from the front with specialized equipment, and they can get up, they can get walking the same day, get out of the hospital that day or the next day. Again, that's with anesthesia, nerve blocks, and making sure that you have that prehab. If you come into it with upper body strength and ability to ambulate, and you have somebody at home to take care of you, people are getting out of the hospital in 24 hours. But the dislocation precautions go away. There's a little incision in the front. You can bend your knee, you can bend your hip, and rotate as much as you want without restriction.
She's doing water aerobics.
Yeah. As soon as your incision heals up, you can get back in the water.
Now, what is the material used?
The material, different companies make different materials, and there's the part that goes inside the bone, which is mostly made out of titanium, which has the same kind of material properties as bone does, and it's very, very strong material. And then the bearing surface, what actually touches against each other, is either highly cross-linked polyethylene or ceramic or metal on metal, ceramic, or metal or ceramic. Those are the two big on the ball side.
Well, who determines what you're going to use? For each patient is different needs?
We have a frank discussion with everybody of the pros and cons of each one.
Okay. Wow, to me that's just amazing, because I can remember 10, 15 years ago, people had hip replacement and they were in a wheelchair, they were walking around forever until they came about.
The treatment of arthritis, if you look at all the different studies that are done, the money spent for hip and knee replacement and kidney transplantation are the biggest bang for our buck.
Really?
It gets people their lives back. It gets people productive again, paying their taxes, because we all have to do that. It just gets, the quality of life is improved vastly. Now, having said that, is it perfect? No. I think anytime you make an incision, there's potential complications, and I think everybody has to talk to their surgeon about their particular set of circumstances. What else are you bringing to the table? If you buy an old house If you ever watch This Old House, and if they're trying to sell it to you, you know, if you just say that it needs new floors, you know, and it's an 80-year-old house, you got to always look at the heating, ventilation, air conditioning.
That's
You
right.
got to
There's
look at the
other
roof. There's
issues.
other issues. So
That's
our
right.
heart, our lung, our you know, infections at other areas of the body. We have to look at all those different things. We can't just look at a knee. The knee bone's connected to the rest of your bones.
I think that was a song once.
It was a song.
That's right. Let me ask, I had a friend, and for years he said, oh, I have a really bad back, and he was getting worse and worse. And he finally went to a surgeon or to a orthopedist, I don't know, and turned out it was not his back, it was a hip problem.
Yeah.
So is that oftentimes?
It's very common. I just talked to one of the neurosurgeons earlier today, and he basically said, I sent you 3 patients that, you know, he saw for the back that turned out to be the hip. And vice versa. We think it's the, you know, they come to us for hip pain and it could be a back. Same thing with shoulder and neck. So really to try to drill down and look at everybody that comes into your office, every customer that comes in your office specifically, and take time to make sure you know where the pain is coming from.
Well, Dr. Nyack, what can we do earlier in life to maybe prevent some of these issues? I know arthritis is arthritis, but what can we do?
Well, I think there's certain variables we can all control. For lower extremity, knee, hip, ankle, you know, one of the biggest things is weight. You know, every year we gain a pound. After 10 years, that's 10 pounds. After 30 years, you know, you can do the math. And I think it's an epidemic. Your cartilage, my cartilage, and somebody that weighs 500 pounds, there's no difference between the cartilage. It's all tissue. And if you subject it to that much force over that period of time, it's going to wear out. So if we can reduce the amount of stress on our knees, on our joints, on our backs, I think they'll last a lot longer. And that's been proven time and time again. So one of the best things we can do is exercise. I think weight loss is one of the key things that we can do. And not, you know, as we advance, you know, the type of exercise that we do, you know, the pounding exercises, running, I think is great, but we should do that in moderation and include other things like bicycling and, you know, I think the yogas and the Pilates need to be added into there. I think the health plexes of the world, the Beachmont Racket Clubs of the world, all these health clubs, YMCAs, you know, they're there as an outlet, and this being January, you know, we should all make and stick to the New Year's resolutions to try to maintain our ideal body weight. And you should really check with your family doctors, internists, to make sure that, number one, you're healthy enough to exercise, and number two, what is your ideal body weight? It's not the same for everybody. But
that's right. Some people are big boned, some are small framed. Yeah.
Within a certain range, though, we're all pretty much, you know, supposed to be in a certain range. So.
So do you think it's important, say, if someone has feelings like, oh, this isn't right, should you go and deal with it first, maybe get physical therapy to prevent it from getting worse?
It really depends on the level of your pain, I think, and whether you've had an injury or not. If you have minor pain that can be alleviated with a little bit of rest, ice, anti-inflammatory medication taken occasionally, I think that's perfectly fine to continue on. Now, if your pain escalates, or if you have, you know, certain symptoms of giving way or a specific injury that you can't walk for a while, those are danger signs. So, you know, the best place to start is with your family doctor, your trusted internist that you've had a good relationship for a long period of time. Ask their opinion, and they're able to do a lot of things for you. And tincture of thyme usually cures most of our aches and pains. So
It does.
I don't want you to, you know, run to the doctor on every ache and pain. So, and I think a lot of people are looking at the internet for answers right now, and you know, that's kind of plus minus. Self-diagnosis, exactly, and I probably do that a little bit as well. But if the pain is to the point where it is affecting your quality of life, and it cannot be controlled with rest, anti-inflammatory medications, you know, icing, those types of things, then obviously I think you should, you know, seek medical attention. Now, where should you go? Again, start with your family doctors first. Make sure that they can help you out with the situation, because a lot of the stuff goes away without surgeons getting involved.
Exactly.
Now, if it still is problematic for you, there are other outlets. We have an after-hours clinic at Wellington that you can go through every day from 5 to 9 without appointments. And these are for, I've fallen and I think I've broke something, or I twisted my knee and I can't put weight on it. Instead of going to the emergency room setting and waiting for, 2 or 3 hours and the cost associated with that, this is something that we can see you, evaluate you, order the appropriate testing, bracing, physical therapy, and try to get you back on the road at a convenient time for you, as well as the cost issue. And then we can set you up with the appropriate orthopedic surgeon, whether it be your knee, your shoulder, hand issues. We have different doctors that have subspecialty interest in all those areas.
I see. Now, on a more personal note, this is such an exacting, and I can imagine the stress sometimes when you're in surgery. What does Dr. Nyack do to relax?
I have to say, spending time at home with my family is probably the thing that relaxes me the most. Unfortunately, I don't have too many hobbies. Fortunately, maybe. I don't play golf. I don't even own a set of golf clubs, but really...
Well, that's good. That would add to
good
your
or bad,
frustration, I think.
Yeah,
Well,
but really spending time with family and friends, I think, consumes most of my time. I have 3 wonderful children and a wonderful wife that, that's really what we live for. So try to spend some time together.
now, your wife was involved with, what is it, the Run for the Forest Hills School District?
Yeah, it's called the Forest Hills 5K. It's an idea. She's a big runner. She's run all her life and exercised all her life. And she approached Mercy, approached Wellington. Basically, she asked me for money, and I asked the guys at Mercy for money, and then she put on a race. But that's
That
not really
works.
what happened. She put in an incredible amount of time. She and one of her best friends, Beth Davis, and they put together an amazing program where the first year they put it on, they had 2,000 people run this race. It basically went from Nagel Middle School up to Mercy Anderson Hospital, back down to Nagel, and up to Clough and back. 5K, very well received. And every year they've done it, they have the monies that they've raised does not go to the Nyack Foundation, by the way. It goes to
I'm so
Forest
sorry.
Hills School Foundation,
Foundation.
which was recently formed probably about 5-10 years ago to try to really boost the educational experience here for Forest Hills. Other schools have a very good alumni association, and this is kind of loosely filled to try to bring that back and give back to the community. So, and it goes back to what we were saying about, maintaining your weight. What would happen if you could get that instilled in our young kids? So, to her credit, she has really motivated all of our middle schools, our middle school and all our elementary schools, 6 of them, to have running programs. There's 900 kids now that are running in the springtime,
Wow, isn't
5K,
that great?
to try to get prepared for this race. There's individually timed events, so you can try to beat yourself. There's age groups that you can, compete with. And it's a way to bring the whole community together. All the schools come together. There's a mascot race that she does. That
Really,
all
with the
our
dogs?
no, the mascots for the
Oh.
various schools.
I thought you
Do
meant
that. They have
okay.
they have the sports teams. The Bengals and the Reds. Rosie Red comes down, and the
yeah.
local businesses come down and showcase all their the support to the community that way. The La Rosa's people come and give pizzas away. The Kroger's here has done so much for us, and all the Mount Washington Care Center has done big sponsorship as well. So it started off as a way just to get people to run. I've seen so many families come in. I had a mom come in with a knee problem once, and I asked her what was going on. She said, "I'm training for this race with my kids. I'm not a runner, but my kids are, and I just want to run with them."
Oh,
So it brought a tear to my eye.
I bet it did. I bet it did. Well, your wife has brought so much to so many people, and you have also. Thank you so much, Dr. Nyack, for all you do for your patients, for our community, the education level that you bring to front. Thank you.
Thank you, Carol.
And thank all of you for watching Anderson Community Television. This is Carol Donahue saying farewell and be healthy.